Good evening, friends. So now we will be discussing ICU preparedness for viral outbreak. I think this talk would have been useful if I am doing it before the COVID outbreak. So now we know how to prepare the ICU, what all things has to be done. And before starting the talk, this outbreak, epidemic, and pandemic, these terms are most of the time interchangeably used. So usually outbreak means a small cluster, and an epidemic, we have many group of patients in that area. And usually pandemic, like a COVID, it's a large number of patients in different areas. And your strategies also will differ depending on the phases of a pandemic or an outbreak. Sometimes you can have a defined clusters in the community, and undiagnosed individual cases you can come across, and sometimes you can get undiagnosed clusters also. So the approach usually depends on, you have to anticipate that you can get an outbreak. Then early detection is always important, especially the unusual viral outbreaks. Then obviously you should be also the part of containment. The early detection, obviously you should be prepared in terms of different aspects, like the clinically you should be able to pick up the case. You should have a proper lab backup how to diagnose that. And obviously, once you diagnose an unusual disease or like a viral outbreak, then you will have to involve the health authority also to contain the disease at a early time. So how we can rapidly identify an outbreak? Obviously, the history is always important. Like some unusual points you may be able to pick up from the history, like a similar, the patient with similar symptoms dying in the family or in the neighborhood, or some unusual clinical findings, maybe like in an undifferentiated fever, you may be observing some unusual clinical findings. And if routine workups are negative, like the way the previous speaker was discussing, like if all your syndromic approach and again the multiplex PCR are negative, you should not stop your investigation at that point. Definitely you will have to investigate further and find out what is exact cause, exact etiology. And definitely you should be in contact with a proper virology institute where you can identify the new viruses or the unknown viruses. The unknown virus means like what we usually does is, like Dr. Tyagi has already mentioned, you go for a like a panel of a PCR. So if the organism is already there, you can pick up that. But if it is not there, it will be very difficult to pick that case. So the same thing has happened in COVID also. They are usual, the panel, the BioFire panel, when they analyze different viral pneumonias in that area, that was negative for the viral panel. So that is the point where they thought of a new virus, then did the sequencing and found out this is a new virus. So I will explain how to do that with the few case scenarios which we came across. So this the boy came in 2018, a 26-year-old male with a 3 days history of symptoms. He was having fever and vomiting. There is no history of travel outside. So he was confused when he came to the emergency department. So obviously, with a confused state, fever, an early diagnosis of encephalitis was made. CT head was done. Then he was shifted to the ICU, making a diagnosis of probable encephalitis. So the main symptoms were fever, vomiting. He had the breathing difficulty, but there was no cough, and altered sensorium, and he was extremely restless. So vitals wise, he was tachycardic and he was having high BP. Other than that, all the parameters were almost within the normal limits, like there was nothing abnormal detected at that time. So then we went ahead with the detailed history taking. That point we came to know that his brother also died with almost similar symptoms 2 weeks back. Then after further questioning, they agreed that 3 of the family members are also having fever, but they were having only mild symptoms and they were in the home itself. So this is the point where we we have to think about some clustering happening. And again, a patient dying with similar symptoms a few days back. Obviously, you have to think about illness with 2 weeks incubation period. So we have requested other persons also to come to the hospital. So almost 4 people got admitted by that time. So we have evaluated all these 4 people, and there were some abnormal findings other than the usual encephalitis features like adrenergic response. All these people were having severe hypertension, severe tachycardia, then other unusual features like segmental myoclonus. So initially we thought it's something like they were very anxious, that is why they were making some abnormal movements. But later on we realized that this is segmental myoclonus, and 2 of these patients were having the ptosis also. So these unusual clinical findings you have to always pick up, and the segmental sweating was also observed in these patients. So encephalitis patients, you all will be treating many encephalitis patients, but you may not be seeing these features. So an index patient who is dying 2 weeks back, then the clustering of the patients, then unusual clinical features. So all these things together should made us to think about an unusual viral syndrome. So your clinical examination is important, your history taking is important, and again, you have to see whether any contacts are having similar symptoms. And you have to put all these things together, and then we have decided about sending further investigations. As usual, all the routine encephalitis, the panel were negative. Then we have approached a virology institute in Manipal, then send all the samples. But here also you see we had 5 patients of Nipah at that point of time, and usual all encephalitis we evaluate with the CSF examination and CSF multiplex PCR. Here you see the CSF was negative for Nipah PCR for all the patients, and all the routine PCR was also negative. And the Nipah was picked up mainly from the throat swab and from the urine. That is why whenever you have a suspicion of an unusual viral infections, you have to send all these body samples like urine, blood, throat sample, and CSF. Otherwise, even if it is a respiratory infection, sometimes you may miss if you are sending only a throat swab. The same way, like if you are suspecting an encephalitis, if you are sending only a CSF, you are likely to miss that case. So this is how you should try to pick that. Then after that, we had 2 more outbreaks of Nipah in Kerala. So 2018, I told we have picked the case because of clustering and unusual clinical features. But in 2019, how they picked was that boy was presented to another hospital in Cochin. He had cerebellar signs and the features of encephalitis. They sent the multiplex PCR. So that multiplex PCR was having Nipah also in that panel. So that is why it was picked up. So sending for a multiplex PCR can sometimes help you to pick the disease. But if that is not there in the multiplex PCR, you should not stop your evaluation at that point of time. So the next case in 2021 was again picked up. That patient, that was a child with a refractory status, having encephalitis features. Then MRI was having some unusual features like in Nipah. Then they suspected, sent the sample for Nipah to the Virology Institute and picked up the cases. So this is how we can pick up the rare viral disease cases. So this is another case, like a 56-year-old man from Wayanad was admitted to our unit. He had fever and thrombocytopenia. So the routine workup for all dengue, leptospira, then chikungunya, all were rickettsial fevers were negative. So he was having developing leukopenia along with the worsening transaminitis with a significant SARS response. All the routine workup were negative. The probable initial diagnosis was dengue, but the PCR and dengue NS1 was negative within 3 to 5 days. The antibody response was not developed at that point of time. So then we went and took a detailed history. So he was from a forest area. So the next thing what we will ask is whether any dead monkeys were there in that area. So I think now the diagnosis is very clear for you. What will be the diagnosis? I think those from Mangalore can pick up the diagnosis very easily. So, and again, when we evaluated, the ferritin was also high. Did a S scoring. So the S score was also high. He was having the features of macrophage activation syndrome. So an early macrophage activation syndrome, the fever with thrombocytopenia, coming from a nearby forest area with dead monkeys in that area, you have to always think about Kesanur forest disease. And at that time, at that point of time, the KFD PCR was not done routinely at that area. Again, we have to contact a veterinary PCR lab at that area, and that PCR came positive. We have reported that, and again, in the meanwhile, some 10, 12 cases were reported during the same time. So previously, from Kerala, the KFD was not reported. So that is how we can pick up the case. And this is the third case. Again, a 28-year-old lady who returned from Bangalore. She had fever, body ache. Along with that, she developed rashes all over the body. She was very anxious, was having some breathing difficulty. Then shifted to the ICU. She was not having all the indications for an ICU admission. Then she had dengue-like picture. The NS1 PCR, all tests were negative. Then, like on detailed examination, she had severe conjunctival congestion than the routine pictures. So what else we can suspect with all these features? Again, our usual fever PCR panel, it was looking for all the routine dengue, leptospira, rickettsia, all those things were negative. Then we sent for a Zika PCR positive. That was also kept ready because during the same time, Zika was reported from some other parts of Kerala also. So the Zika PCR was there. So we sent a Zika PCR, then Zika PCR came positive. So we were able to alert the area at that time. So this is how we can pick up the cases. And now we have many patients coming with viral pneumonia like picture. I think in Bangalore also we have the similar situation. Many of them are having severe myocarditis. Then acute kidney injury, rhabdomyolysis. Many of them are H1N1 negative and COVID negative. Few of them are H1N1 positive. So majority of the time when we suspect influenza, we send for H1N1, and if it is negative, we think it is not H1N1. But here, again in the other panels, the influenza A was coming positive and H1N1 was negative. So probably these cases will be H3N2. We specifically collected all the similar samples, which is positive for influenza A and negative for H1N1. Then we collected the similar samples from the nearby hospitals also, and later it came H3N2 positive. So basically now there is an H3N2 outbreak going on in North Kerala. I think in Bangalore also you have the similar outbreak. So what we did further was the genomic sequencing from Institute of Genomics and Integrative Biology. So we have collected all these samples and sent for the detailed sequencing to IGIB so that those reports are awaited, whether it is H3N2 itself or any variation is happening. And if the patient is having a travel history, what we can do, I think you all will be familiar with that. So if you go and register to this ProMed site in ProMed.mail.org, so you will get the alerts like what all outbreaks are happening at that time. Or if you are getting a patient with a travel history to say South Africa or somewhere, so you go to that area, so all the outbreaks reported in that area will be given there. So we can further see the similar the features are there. Then we can ask for the PCR for that specific virus. So that is also possible. Then obviously, when we suspect such cases, we have to immediately isolate. The strict infection control practices should be done. So this is also important along with the diagnosis of such unusual viral outbreaks or new viral outbreaks. Whenever you come across such viral outbreaks, immediately you have to isolate. The precaution in undiagnosed febrile patients is very, very important, and contact monitoring is also important. So whenever you suspect such cases, the contact monitoring is also important. And when in doubt, you have to immediately report to the authority, and they should be also in the loop, and they should also investigate whether similar outbreaks or similar cases are happening, and contact isolation. And you have to get from the support from the community as well. You can utilize the media, everything to alert that there is such an outbreak is likely to happen. And obviously, along with that, these things I think you are all familiar. You should be able to prepare with all other mechanisms. This is basically for a pandemic, not for an outbreak per se. And the negative isolation room should be there in all the ICUs. I think now all the hospitals are having negative isolation room. Even in the cost constrained units, you can have these negative pressure isolation rooms. Like you can put an exhaust system. If you are having an air handling unit, that the inlet can be kept like that, but the outlet should be closed, and you have to put a separate exhaust fan. You can put the exhaust fan like this. This is the industrial grade exhaust fan. I think this is how we can convert the normal rooms into the negative pressure rooms. So this is all for the like many number of patients when we are getting. Definitely you should have a the plan for increasing the capacity, and definitely all the ICU specific measures like putting the filters in the expiratory port, and other all infection precaution measures should be taken once you have a doubt of some unusual viral infections. Thank you so much.